This is a case of small lymphocytic lymphoma, chronic lymphocytic leukemia, presenting as bilateral inguinal lymphadenopathy. Small lymphocytic lymphoma and chronic lymphocytic leukemia are considered two clinical manifestations of the same disease, defined by the accumulation of mature appearing but functionally incompetent B lymphocytes. The pathogenesis is largely driven by defective apoptosis, leading to progressive lymphocyte accumulation in blood, marrow, and lymphoid tissues. SLL, CLL is the most common leukemia in adults in Western countries, usually affecting older adults, though it may occur in middle-aged patients. Clinical manifestations range from asymptomatic lymphocytosis or lymphadenopathy to systemic symptoms and immune dysfunction. Diagnosis requires histopathology and immunophenotyping with the characteristic co-expression of CD5 and CD23, helping to distinguish it from B cell neoplasms such as mantle cell lymphoma. In this case, this is a 52-year-old male patient with hypertension who presented to the clinic because of 2 months of painless bilateral inguinal masses. He reported prior daily alcohol abuse, but he had discontinued it last year. He denied at this time fever, night sweats, and weight loss. On examination, it was confirmed the bilateral inguinal lymphadenopathy without hepatosplenomegaly. A contrast-enhanced CT scan of the abdomen and pelvis demonstrated extensive mesenteric, retroperitoneal, iliac, and inguinal lymphadenopathy. The inguinal lymph nodes were suitable for image-guided biopsy, so we went ahead and proceeded with the test. And histopathology and flow cytometry confirmed the SLL-CLL. The specimen also shows CD5 positive monoclonal B cells with thin surface kappa light chain restrictions. Cells co-expressed also CD19, CD20, CD5, CD23, CD22, and were negative for CD10, FMC7, and CD38. The CD4-CD8 ratio was approximately 3:1 without antigen loss or gain. The lymphocytes appear morphologically mature. Here we also share with you 2 photos for this patient so you can have an idea of how the SLL-CLL looks like on microscope and on peripheral blood smear. So we also want to share with you that SLL-CLLs account for nearly 1/3 of all leukemias in the Western countries. As we mentioned before, it is usually indolent, with many cases diagnosed incidentally. The diagnostic hallmark is a monoclonal B cell population expressing both CD5 and CD23. The immunophenotype distinguishes SLL-CLL from other entities such as mantle cell lymphoma, which is CD5 positive but CD23 negative. This case highlights the importance of including lymphoproliferative disorders in the differential diagnosis of persistent unexplained lymphadenopathy, even in younger patients. Definitive diagnosis requires biopsy and immunophenotyping, which remain the gold standard for distinguishing SLL-CLL from other B-cell malignancies. Thank you.